Thank you so much, sir. Thank you, AIOS, for giving me the opportunity. I'm Dr. ANUSHA AJWANI, and today I'll be speaking about post-Lasik epithelial ingrowth, its causes, features, prevention, and manage. I'll try to be quick as far. So, epithelial ingrowth is the presence of corneal epithelium in an area where it does not belong, and after Lasik, it occurs in the interface between the flap and stromal bed of the patient's cornea. The incidence following primary Lasik is very low, estimated between 0% to 3.9%, and it is increased when the flap is lifted for retreatment or enhancement, ranging from 1.7% to 23.3%. The corneal epithelial cells can be introduced into the interface in two ways. Firstly, during the microkeratome pass or other parts of the procedure, and secondly, due to a loss of contact inhibition and the presence of a pathway to the interface. Coming to the risk factors of epithelial ingrowth following Lasik, these can be non-modifiable risk factors and modifiable risk factors. The non-modifiable risk factors include patient factors like presence of corneal epithelial basement membrane dystrophy, history of recurrent corneal erosion, type 1 diabetes mellitus, older age group. Hyperopic Lasik is at a higher risk of developing epithelial ingrowth as compared to myopic Lasik. Microkeratome assisted is at a higher risk of developing epithelial ingrowth. Prolonged manipulation of the flap and excessive instrumentation at the interface, partial flaps, flap misalignment or dislocation. Coming to the modifiable, the surgical technique used during retreatment is also responsible, and there is a higher incidence of ingrowth with direct flap lift with forceps as compared to cleaving with spatula before the lifting. Corneal epithelial injury, buttonholes, and spillover ablation at the bed margin. Coming to the classification, so based on the location, clinical features, and severity, it can be classified into 4 grades using the Provost-Machart classification, and this classification serves as a useful aid for consistent and standardized grading and provides guidance on the treatment strategies. According to this classification, the grade 1, in this there is a thin growth, well delineated white line along the advancing edge. There is no flap change. The location is within 2 mm of the flap edge, and usually no treatment is required. In grade 2, there is a thicker growth. No demarcation line is there along the nest, and they may have rolled or gray flap edge with no melt. Usually no urgent treatment is required. However, patient may need it within 2 to 3 weeks. In grade 3, there is pronounced growth. There may be presence of opaque ingrowth, geographic areas of necrotic cells with no demarcation line. Usually urgent treatment is required, and the location is usually more than 2 mm from the flap edge. In grade 4, there is aggressive growth which may result in flap melting, which can threaten or affect the visual axis, and urgent treatment is required. Coming to the prevention, so to avoid epithelial ingrowth, patient selection is very important. Patients with the stated risk factors may achieve better results with PRK than with Lasik, thus avoiding the possibility of epithelial ingrowth. Apart from that, we should avoid prolonged manipulation of the flap, clear any epithelium, tags or debris from the stromal bed prior to flap repositioning, apply BCL when epithelial defects are observed. It is always a good idea to use new blades, and with minimal and careful use of topical anesthesia. Coming to the management, so for mild and non-progressive epithelial ingrowth, that is grade 1, no treatment is usually required. Carefully, we need to observe the patients to ensure that there is the growth is not progressing. Intervention is needed only when epithelial ingrowth appears to be progressing or affects the visual acuity or causes flap melting. So the most common treatment strategy is mechanical debridement of epithelial ingrowth from the flap stromal interface and from the inner side of the flap, followed by careful repositioning of the flap and avoidance of any intraoperative or postoperative epithelial trauma. It is a good idea to resect the epithelium from around the flap bed. Use balanced salt solution to irrigate the interface, the flap, and the stromal bed to ensure removal of all the epithelial cells. Then replace the flap, followed by placing a BCL. Flap suturing, fibrin glue, and ocular hydrogel sealant at the flap edge have been proposed to facilitate secured flap adhesion. In refractory cases, various adjunctive therapies such as ethanol, mitomycin C can be used to help eradicate epithelial ingrowth. Amniotic membrane grafting can be used in cases associated with flap injury or melting. And in severe ingrowth with melting and folds, it is better to remove the flap and allow for self-healing. The use of ND-YOG laser has also been proposed as a novel technique for treating epithelial ingrowth. It produces short individual pulses of focused infrared light, around 30 to 40 pulses of low energy, focused slightly posterior with respect to the epithelial growth and starting in the center. The power is adjusted to the minimal amount to form bubbles. At the margin of each bubble, new spots of laser are shot until the entire area of epithelial ingrowth is treated, thus sufficient for blocking progression and to decrease the size of epithelial ingrowth. So here are certain images. In the first image, we see that the epithelial ingrowth is there at the interface. In the second image, this is after 1 month, after one session of ND-YOG laser treatment, epithelial ingrowth has well-defined borders. In the third image, it is at 1 month after second session of ND-YOG laser, and epithelial ingrowth has further decreased in size and density. And the fourth picture is 2 years after ND-YOG laser and demonstrates minimal scarring in the interface at the site of previous epithelial ingrowth.
You have to complete now.
Yes, ma'am. Last slide only. So coming to the conclusion, with the continuing rise of Lasik procedures, it is important for all ophthalmologists to be competent in recognizing and managing the post-Lasik complications. When appropriately managed, good visual prognosis is usually achieved, and the use of chemical adjuncts and interventions may be required in aggressive or refractory cases in order to achieve complete and permanent eradication of the disease. Thank you.
Thank you.